She is at present a consultant endocrinologist at Sarvodaya Hospital, Faridabad, Haryana. She is member of the Endocrine Society of India and Endocrine Society. She was awarded second place in prestigious ESI AV Gandhi Award for Excellence in Endocrinology in 2022. She has got various national and international publications. She is a prolific speaker. I think this is her third time to my memory in our forum. We had one in Panchil Randavu, we had one probably in Surya, and this is the third one. Okay. Today is a very important topic. We have spoken, heard, listened on this topic several times. More you hear on this topic, the more you want to hear on this topic. It's such a clinically relevant topic. NAFLD, which was initially called as NAFLD, it's got great relationship to one of the most bottom line issues in diabetes called insulin resistance. It is also I would say a surrogate marker of lowered HDL cholesterol, and therefore if you have somebody with MASLD, you can bet that this fellow would have low HDL cholesterol and would have very high HOMA-IR. So, and we know from our experience and learning from diabetes that these two things make a cocktail for a very highly atherogenic environment and therefore adverse cardiovascular diseases. Dr. Naveen, I would like you to come here today. I want you to observe everyone because a lot of people make noise. So I want to make sure that no one makes noise. So I want you to make a lot of those people who are making noise today. And I want Devin, I want you to serve Dr. Naveen right here.
I'm already served.
He promised me that today he will be our policeman.
Sir, आपकी appetite खत्म हो गई है.
So he'll be here. He'll be here.
Okay. Monitor.
Last monitor always sits in the front. Dr. Bhawna Attri will take us through this important topic, adding a new dimension in the management of NAFLD. Please note down your questions. My request to you with folded hands is to please keep decorum throughout the meeting. You can ask questions, there is no problem, as we are starting right at 9:07. I think we hope to finish by 9:30, 9:35 and we can take it up to 10:10. So you have about 30-35 minutes for interaction and we can all be home by 11 o'clock if we all are disciplined. So over to Dr. Bhawna Attri. Friends, ladies and gentlemen, I want to welcome you to CME number 922. Over to you, ma'am.
Good evening, everyone, and I would like to thank all of you here, lovely audience. Yeah, sir was correct. I think most of you for the third time. And in the last two meetings, I think I also got to learn a lot from all of you. I think we all can share the knowledge today. And today's topic, NAFLD or MASLD.
स्लाइड देखना है.
Slide. अच्छा इसमें क्या लगाया वो?
So today's topic is adding a new dimension in the management of non-alcoholic fatty liver disease that we call as metabolic syndrome associated fatty liver disease. Because we don't want to call it as a non-alcoholic, it's better to coin the term metabolic syndrome associated so that we can include all the associated factors that lead to this condition, that increases the progression of this condition. So insulin resistance is the common link for the various metabolic conditions we have, be it obesity, dyslipidemia, hypertension, diabetes, pre-diabetes, impaired glucose tolerance, and again then we call it as non-alcoholic fatty liver disease. So what happens in non-alcoholic fatty liver disease? There is insulin resistance. Because of that, the fuel disposal in the body is not occurring as it is supposed to occur. We have a lot of substrate in the circulation of these people, like free fatty acids and glucose, that is not being disposed properly where we want it to be disposed. Like we want, if the blood glucose is there in the circulation, it should get oxidized. It should not be free lying in the circulation, so that we have limited quantity of fatty acids. If we have a lot of fatty acid pool in the circulation that is being not taken care by the adipocyte, this fatty acid pool will be delivered to the liver. It will get deposited there, leading to fatty liver. Over a period of time, inflammation will set in. There will be histological changes in the liver, like we call it as a hepatocyte ballooning, inflammation. That will go on, and the fibrosis will set in, and then it can lead to the term cirrhosis and can lead to mortality, hepatocellular carcinoma, and so on. So I think the insulin resistance, we can call it as an important link between all the conditions of metabolic syndrome, including the non-alcoholic fatty liver disease. Talking about the prevalence in India, we know that we Indians are quite prone to the metabolic syndrome. Our diabetic patients, they develop all the complications very early, and the complications are also very severe. Why? Because we have that huge burden of visceral obesity. So metabolic syndrome prevalence is quite high in India. Type 2 diabetes, the data from 2019, 77 million people living with type 2 diabetes. Atherogenic diabetic dyslipidemia, where we find a high TG, small dense LDL, low HDL in almost 34% of people. Then NAFLD, the prevalence is around 32%. I can assure you, these are the numbers that we are getting from the urban India. The huge burden of disease is unreported here. So we can really see the numbers that are really going to be very, very high. So NAFLD is a neglected epidemic. It's because in our books also, few years back, we used to say, okay, till now the guidelines say routine screening of micro and macrovascular complication in a diabetic patient. So we used to screen for neuropathy, nephropathy, if symptoms are present, then for cardiac complications, but not frequently we used to talk about NAFLD. But in the last few years, seeing the epidemic of this problem, we need to understand that people need the routine screening, and that is the first step where we can detect them early, we can bring some intervention, and we can prevent their progression to cirrhotic liver disease. So this is the progression that we see in the MAFLD, where there is a normal liver. With time, fatty infiltration in the liver will happen. If that is not taken care of, then inflammation will set in. That will be then followed by fibrosis, and the fibrosis will go on, leading to irreversible cirrhotic stage. So the diagnostic criteria for the liver biopsy for diagnosing steatosis, it is more than 5% steatosis in liver with the presence of insulin resistance. I would discuss about what is the diagnosis of MASLD. How do we define MASLD? It is basically a person who has any of the metabolic syndrome that we know of. Along with that, the patient has got steatosis. Whether we do it because we do it non-invasively usually through ultrasound or through the elastography, and other etiologies specific for the fatty liver has been ruled out. Sometimes a person may have alcoholic liver disease with metabolic syndrome associated liver disease, and that category is the more severe one. So anyone with metabolic syndrome with fatty liver or steatohepatitis is called as MASLD. Talking about the comorbidities, they are quite linked. So we have to screen a person with metabolic syndrome for MASLD. Also, if someone has got MASLD, then we should screen for other cardiovascular risk factors as well. So In a clinic, if we see a person, diabetes, obesity, dyslipidemia, blood pressure, or PCOD, or obstructive sleep apnea, it's important we should look for is the patient having MSLD or not. And similarly, if someone has got MSLD, then look for other parameters. So the overall prevalence of NAFLD in India is up to 32%. But this prevalence in the population where would be more interested, like in obesity, it is around 80%. In patients with type 2 diabetes, the prevalence of NAFLD is 70 to 80%. And not just the percentage of this MSLD is high in this metabolic cohort, but the rate of progression to end-stage cirrhosis or HCC is quite high in the people with obesity or diabetes. What is the pathophysiology behind the fatty liver? In a, let's say, example of a diabetes patient, as I said, someone with obesity or diabetes has got insulin resistance. Insulin is not working properly. So the job of insulin is the glucose disposable at the various site. If glucose is not being disposed, the proper oxidation of glucose and the proper oxidation of fatty acid is not happening. We have a huge pool of fatty acid in the circulation, which will then go to the fat liver, and then the process will start. So how does the fatty infiltration in the liver causes this NAFLD, and how does this fatty infiltration lead to other cardiovascular risk factors? So what happens, this fat infiltration and this inflammation leads to endoplasmic reticulum and mitochondrial dysfunction. This happens not only in the liver, but it is happening in almost every organ of the body, leading to inflammation, apoptosis, and so on. So if it is a liver, there will be lipogenesis, inflammation. If it is muscle, where we expect a good beta oxidation of glucose should happen. So now this will not happen. There will be lipogenesis in almost every organ of the body. We have seen a patient, not just the fatty infiltration in their liver, but also in the pancreas we have seen. So this is how, and in the myocardium also they develop this fatty infiltration in the inflammation. So every organ is now getting damaged with the fat and inflammation, and there is dysfunction at the level of cell, subcellular level. So NAFLD is a precursor of cardiometabolic complication because the pathophysiology is the insulin resistance and inflammation. So person is prone to develop cardiac condition, cardiomyopathy, CAD, SCVD, prone to develop myostatosis, further impaired glucose oxidation, then the vicious cycle sets in, and prone to develop the diabetes. Dyslipidemia, again prone to develop ASCVD. So all the conditions are actually linked. This is again a slide which is showing the association of comorbidities with NAFLD, including metabolic syndrome. So what these slides are basically telling us that we cannot screen all the population, but yes, we need to screen the people with metabolic syndrome for NAFLD, because the prevalence is quite high in this group and the chances of progression is also quite high. And the real world data suggests that there is a huge diagnostic gap in screening of NAFLD. Like this is a European database which has included almost 2 crores of people, and in this almost 1.7 CR people had more than 1 year of data. The incident rate of NAFLD was only 1%, although the prevalence of NAFLD in this population was quite high. So, see, what does it mean is that we are not actively screening. If European countries are not actively screening, we can see the burden on our part where the major problems are not being screened routinely. So, we need to address this problem. Talking about the clinical presentation, mostly initial stages, these people are asymptomatic. Some can have the vague symptoms of fullness, but mostly they are asymptomatic, and good proportion of people will not have deranged LFT. So we will not say, okay, this patient has a normal LFT, I don't want to screen for NAFLD. No, a good percentage of patients, in fact in the later stage when the fibrosis goes to a higher stage, this OTPT may be normal. So annual review is important. In the metabolic, I say clinic where we are dealing with, all of us we deal with obese patient with hypertension, patient with CAD, so we need to screen at least annually. all the guidelines, whether it is American, European or ADA, they all tell us that screening of NASH is an important part. According to ADA, NASH and fibrosis screening recommended in people with type 2 diabetes or pre-diabetes and elevated ALT or fatty liver. So 5 to 6 years back in our textbooks of medicine and endocrinology, I would not say it was strictly recommended. It should have been, but now it is being incorporated because the most common cause of, I would say, chronic liver disease in India is becoming now the metabolic syndrome, insulin resistance, obesity, not the alcoholic conditions. So AST-ALT ratio does not rule out the NASH. Liver enzyme may be normal in 80% of these patients. They are not the sensitive marker for NASH or NAFLD. There is a poor correlation between the ALT and the histology. Histology severity is similar in NAFLD patient with the normal or abnormal liver enzyme. So if there are deranged, we can be more, this patient may have NAFLD, but if it is normal, it is not helping us out because it is not a sensitive marker. So how clinically we should go ahead? So one thing is clear, the prevalence is quite high. The prevalence is high in the people with cardiometabolic syndrome. So what should we do now? How do we should proceed with the screening part? This is simple tools, multiple tools are available, and the FIB-4 score is the simplest one out of these, which can be easily done in the routine clinical practice. It just requires 4 parameters: age, AST, ALT, platelet count. And you put in the Google, there's a calculator, you get a reading. So if you get a reading something less than 1.3, that it usually rules out. I would not say 100% of patients, 10% it still may miss. But for the screening, it is a good modality. If it is less than 1.3, you can ask the patient for a follow-up. You may not proceed with a further imaging. But someone with FIB-4 score of more than 2.6, I would definitely go for further imaging. In fact, between 1.3 to 2.6, especially the people with the multiple cardiometabolic risk factor, I would go for this thing. So the only use of FIB-4 score here out is, if the FIB-4 score is less than 1.3, I may ask the patient to come to follow up after a year. But if it is more than that, I would investigate further. So in our clinic practice, if someone has got carrying a ultrasound report with fatty liver, that is very common, or deranged LFT in the report, or per se, the patient has got metabolic syndrome, we can sit and calculate the score and we should proceed for further investigation or further action. So this is how we can calculate it, just need these 4 parameters. So what next? We have taken the history, we have an examination, we calculate the good score, and we have the LFT report. So we can do this transient elastography. The common term is fibroscan, which is now available at multiple places also. So here actually it provides us the 2 parameter. One is the CAP score, one is the LSM score. LSM is a liver stiffness measurement. CAP is the control attenuation parameter. So we get 2 readings. It's a simple non-invasive test. We just ask a person to be NVM for 4 hours, and the patient can come, and within 5 to 10 minutes we can have the reading. So LSM and CAP. LSM tell us about the fibrosis, the fibrotic stage, and CAP tell us about the fatty infiltration, steatosis. I would not say it is 100% sensitive or the specific modality, but yes, we are able to pick out a good number, and more important, we can actually say, okay, this is fine, you can go. So by that way, it's a simple modality. If it is available, one can go for it. Confirmation is by the liver biopsy, but unfortunately, no one wants to go for an invasive procedure so early. So usually biopsy is not done in the routine cases until and unless we are thinking of some specific etiology of liver disease, like in monogenic disorders or in some infiltrative disorders or like Wilson's and so on. There we may go if we are not accurate about the diagnosis. In fact, in Wilson we don't want. We have the routine urine and blood investigation. So liver biopsy, we don't usually go with it. So this was about how do we screen, how do we diagnose, and now next part is the management part. So we have a patient who has got fatty liver, NAFLD, MSLD. We have a report available with us. He may be having F1, F2, F3 in the this fibroscan report, or maybe scanning an ultrasound grade 2 or 3 fatty liver. So what to do now? The management, the most important step in the management is to break the insulin resistance, and that can be done by the weight reduction. Weight reduction is the most important treatment modality. If one can do it, then definitely we will see the result. But unfortunately, it is the most difficult task for anyone, especially to sustain that lost weight is very difficult. So, talking about, apart from the diet and the exercise that we tell to our patient, the pharmacology, in the diet and exercise, the basic, I think, the diet I tell to my patient is deficit of 500 kilocalorie. Because we don't have that much of time to discuss in detail about the diet. If someone has a dietitian, that is wonderful. If not, at least we can give them some time, give them special, because in the routine practice, we usually know what 5 to 6 mistakes the person is doing. We can inform about them. We can tell them, okay, do the deficit of 500 kilocalorie in your diet. Do it consistently for 3 to 6 months. You will have some result. Because for any weight loss to be meaningful, it should be at least more than 5 to 10%. Then only there will be results. So weight reduction is very important. Again, second thing is exercise. Depending upon how much a person can do, we advise like at least 5 days in a week it should be incorporated. Both aerobic as well as resistant training are important. Especially in an Indian scenario where we want the loss of visceral fat and the gain of muscle bulk, the resistant training is very much important to correct the metabolic parameters. So for the aerobic exercise, we tell about 150 minutes per week of moderate intensity exercise or 75 minutes per week of vigorous exercise, and some sort of resistant training along with that. So this is the routine that we tell to our patient, but it can be individualized depending upon the need of the patient. So what next? In the pharmacology, you should take care of all the cardiometabolic risk factor the patient is carrying. The patient has got hypertension, should be taken care of. The patient has got diabetes, dyslipidemia, should be taken care of. Obesity, weight loss. Then what is the MASH directed therapy? So unfortunately, we don't have much MASH directed approved therapy as of now. There's one drug, resmetirom, which is called thyroid hormone receptor beta agonist. We don't have that. Some RCT phase 3 trial have shown the results. So where it is available, it has been approved in certain areas, it's being given, we don't have that yet. So usually the treatment that we have, apart from saroglitazole, is not MASH directed. It is what we're trying to achieve is the weight loss by various means, and then we are targeting the treatment. So here we are today to see the role of saroglitazole, where we can fit into the management of MASH. So as I said, the diet, exercise is very important. Bariatric surgery, if someone needs bariatric surgery for other reasons, for the obesity or the complications, then definitely bariatric surgery is going to improve the MSLD condition as well. But as of now, alone for MSLD, bariatric surgery is not approved. Talking about how much weight loss is required, 5% weight loss will bring down steatosis. 5 to 10% of weight down will be able to bring down steatosis hepatitis, and more than 10% will be able to bring down fibrosis. But the challenge is who can maintain this lost weight for a long period of time. Unfortunately, good number of people, they again regain after a year. In pharmacology treatment, so we want a drug which has a good number of trials, maybe phase 3 trial, good of real world evidence, and we see the result through histological improvement, regression in fibrosis. Unfortunately, many of drugs are not showing these results. So these are the various drugs which are there. Few with phase 1 trial, few with phase 2 trial, few with some evidence. So I would say it like vitamin E. Vitamin E is it's an anti-inflammatory, anti-apoptotic vitamin. It's a free radical scavenger. But the problem is the result. It has been used for a long period of time and many people are still continuing it, but we don't have a great evidence. Similarly with the bile acid agents, analogs, we don't have much result with it. But if someone is a diabetic, then pioglitazone, if not contraindicated, could be a good option because it acts through PPA gamma agonist, and then it acts through improving the insulin sensitivity at the level of adipocytes, improving the beta cell, and that drug has been some role in the improvement in the MFLD. For a diabetic person, actually we have a good number of drugs like SGLT2 inhibitor, GLP-RAs, then pioglitazone, metformin. They have some role, some by causing the weight loss, some by direct anti-atherogenic effects. So they are being helpful. So diabetic patient, we have these many options. So now saroglitazole, the drug for today, how does it bridge the link between diabetes and NAFLD? It has been DGSA approved for 2 indications. One is atherogenic diabetic dyslipidemia. We have got high TG level. LDL is not that high, but the LDL in these patients is small dense, which is more atherogenic, and the TG levels are very high in these people. This is the one category where saroglitazole works. Second is the NAFLD, approved in 2020. So the mechanism of action is PPAR alpha and gamma agonist. By alpha action, it is acting on the kidney, heart, muscle, and here it is implicated in promoting the fatty acid oxidation. So it does not let lipogenesis to happen. Then the gamma agonist has got a benefit at the level of muscles, at the level of adipocytes, where it is improving the insulin sensitivity, also promoting the beta cell line. So theoretically, if we see 2 indications, they are very good. We are working at the level of lipid metabolism, at the level of glucose metabolism. So could be helpful in diabetes as well as dyslipidemia and NAFLD. It is not approved for diabetes, but there are results and people have personal experience of improvement in the blood glucose also with the addition of this molecule. So there is a integrated review analysis data published in Diabetology 2019. It was 18 clinical studies including 5,824 patients with saroglitazole. There was TG reduction by 45 to 62%, LDL reduction 20%, A1C reduction also by around 0.7 to 1.6%, improvement in the ALT and increment in the decrement in the non-HDL, around 21 to 36% of patient was seen. This is a 16-week trial, randomized double-blind placebo-controlled trial, single center, where treatment-naive diabetic patient with A1C of 7 to 9% with fasting TG of more than 150 were randomized to receive saroglitazole versus placebo for 4 months. And by the end of the 4 months, the index for the insulin sensitivity and glucose metabolism were improved, where saroglitazole were added versus the placebo. This was a USA study, phase 2, saroglitazole efficacy in NAFLD, evidence 4 study. 104 patients with NAFLD was included. Saroglitazole versus placebo, 16 weeks the drug was given, and the efficacy endpoint basically what changed in the ALT. With the saroglitazole, there was reduction in the ALT by 44 unit per liter, whereas placebo there was increment. Then absolute change in the liver fat content. There was reduction in the fat by 4%. Percentage of people with liver fat reduction by 10% that was there in 55% of patients who were on saroglitazole versus placebo, there was only 28% of patients. And the percentage of patients with liver fat reduction by 30% was there in 41% people on saroglitazole versus 8 placebo. So there were people reduction in the fat, reduction, improvement in the ALT with saroglitazole versus the placebo. This was the big study. The time frame was 52 weeks. Biopsy driven phase 3 study from India. So there was here the endpoint was proportion of patients with decrease in the NAFLD activity score, biopsy score at week 52 by at least 2 points spread across at least 2 of the NAS components. So this was the study where biopsy results was shown, and the study was conducted over a longer period, 52 weeks. So they included 18 to 65 years of people who had histological confirmation of NASH without cirrhosis, and so they were able to see steatosis, lobular inflammation and hepatocyte ballooning in these patients. And the exclusion criteria were the usual one, the pregnancy, lactation, significant history of alcohol intake, then type 2 diabetes agents, other agents which can confirm the results like sulfonylurea, DPP4, prospective observation, real world study, we can see that when we look at the baseline in the 24-week and we look at the parameters, so good number of people were able to achieve the result that we want. Improvement in the LFT, improvement in the lipid parameters, and A1C also we can see that there is an improvement, and fibrosis parameter also improving. Although, see, it is not approved for diabetes, but the mechanism itself suggests that in some people we may have the result as well. So, saroglitazole lead to significant improvement in LFT, LSM cap in NAFLD patient with diabetic dyslipidemia. So, comparing it with other molecules, as I said, like saroglitazole versus obeticholic acid or ursodeoxycholic acid. So, one is the trial, the better trials that we have up to 52 weeks showing the improvement in the fibrosis parameter, biochemical parameters, so on, the significant improvement versus placebo. The trials that were not that much, I would say, power to suggest the results as compared to saroglitazole. And side effects, if we talk about side effects, there is not much concerns in the trial. It has been mentioned in the consensus guideline. Both, RSSDI as well as the Lipid Association of India, they have mentioned this molecule. We can use it for the management of dyslipidemia and MASLD in diabetic patient. So in the summary, I would say that we should consider MASLD as an important cardiovascular risk factor, as an important metabolic condition. As we screen all the complications in a diabetic patient, we should routinely screen for the presence of MASLD. We should routinely screen at what stage the fibrosis someone is lying. Is it like F3, F4, where the patient needs urgent intervention? So we should know when to screen, how to screen. As I said, we have simple parameter, FIB-4 score, fibroscan, ultrasound, AST/ALT. And then the treatment, most important, weight loss, weight loss. And in the diabetes patient, I think the GLP-RAs agent and terzaparatide in the pipeline, where we are seeing good number of patients having significant weight loss. We are hoping this molecule to reach India and we can have good results with that. Again, SGLT2 inhibitor should be given to the patient because many trials are showing the good results with SGLT2 inhibitor. So in a diabetic patient, we have the option of GLP-RA, SGLT2 inhibitor, then pioglitazone if we can give. This saroglitazole is also an important molecule that we have the evidence where we have seen the results in the biopsy itself. So we should provide the benefit of this molecule, and many important consensus guidelines do recommend its use in patients with MASLD and diabetes. I think that's all. Thank you very much.
लाइट जला देना
लाइट ऑफ करना प्लीज डॉक्टर भावना प्लीज भाई जरा ये वॉल्यूम तुम्हारा क्या है माइक क्या है तुम्हारा क्यों नहीं आवाज आती
Can you sit here?
वॉल्यूम बढ़ाओ भाई We had a wonderful presentation, friends. I would request all of you to please contribute to the value of the CME. Please ask questions. It's a very, very important topic. Whether you are a GP or you are a specialist or you are... Okay.
So, yes, Dr. Sajid, I would start the ball rolling. Ma'am, you said, Manish, please come here.
Sir.
Please come here. Pioglitazone is supposed to be a good medication for addressing the issue of NAFLD, MASLD. In your opening remarks, when you talked about the treatment, you said the most important thing, the bottom line thing is the weight. The problem with pioglitazone is weight gain. So on one hand, it is doing wonderful things with transaminitis, with MASLD, with insulin resistance, insulin sensitizer, but on the other hand, it leads to weight gain. Does it not nullify the effect?
Yes, sir. So the weight gain, I think there are two different ways we can see that. So there is improvement on, see, it's acting on the insulin resistance. So by that mechanism, it is going to provide the desired effect in terms of reduction in the steatosis, hepatitis, and the fatty liver. But the weight gain usually that we see with the pioglitazone is the fluid overload, the volume overload. So I would not say that this weight is actually going to nullify the effect. I won't see like that. And with the pioglitazone, I don't weight definitely if someone has this puffiness, volume overload, they'll come back to us. But I think mostly drugs like sulfonylurea, most frequently that we use, insulin, they all cause the weight gain. The problem with pioglitazone is not this, the problem is postmenopausal ladies. I'm really worried about the osteoporosis. Osteoporosis is also one complication of diabetes that is neglected. Many females, even males, diabetic, they land up in ortho department with the fractures. And if you take those patients now, good percentage of them are osteoporotic. But I think giving pioglitazone to elderly patient in my clinical practice should not be preferred. And we see diabetic patients, mostly they are elderly. So that is the one reason. Second, the people with heart failure. The other two categories. And third, if someone has got retinopathy and we are suspicious of CSME, where it can actually aggravate the macular edema. So many times patients don't even do the routine fundoscopy. So that is one place. So my place of pioglitazone is usually a young male, preferably, and female also, who have got MSL.
So you have a very specific kind of a prototype patient for the usage of pioglitazone in the case of MASLD, where you have a youngish patient, obese, and we are absolutely sure that this fellow would have insulin resistance. We are not worried about the osteoclastic versus the osteoblastic activity in this person, and we know that we will not end up with a fracture very soon.
Yes.
So pioglitazone is not the drug of choice for postmenopausal obese women. That is out. That is out. Okay. Now coming to the second molecule that you talked about, which is an anti-inflammatory action, and I'm sure many colleagues will have a lot of questions on that. Vitamin E usage in males, especially in high doses and especially for a longer duration, more than 6 months, has been associated with prostatic carcinoma. Your comment on that?
So there are concerns. As with pios, we have a concern of bladder carcinoma. Here we have a concern of prostatic carcinoma.
Also lung cancer.
Yeah. So that is why we are not, results we are not getting so wonderful. And these days, I think many of us are not prescribing vitamin for MSLD. I haven't prescribed after I did my DM from AIMS. We haven't prescribed anyone vitamin D in my residency. Haven't. None of the doctor. No gastroenterologist, no endocrinologist, no medicine guy. But see, prior, we hardly had the drugs. Now we have SGLT2 inhibitor, we have GLP. I am prescribing good number of patients on GLP-RS. Most of my patients are on GLP-RS. We are giving them, we have to give them. So we have better results, why to give them vitamins? So that slide was in context of what is there in the history and what we have now.
One molecule which was missing from the list was a SGLT2 inhibitor, and there has been a famous study called the EDIP study. Although small study of about 42 patients. Your take on SGLT2 inhibitors, because insulin resistance, insulin sensitivity, low HDL cholesterol, and MSLD are so intricately intertwined with each other in a type 2 diabetic patient. So your take on the usage of SGLT2 inhibitors, are you using SGLT2 inhibitors for MSLD?
So I'm using, I think, most of my patients until and unless it is contraindicated or causing some trouble. Because I really don't see if patient is obese, if patient has got any problem, it has to be SGLT2 inhibitor. GLP-RA is the cost and all those things comes. But and we have seen the result of GLP-RA, SGLT2 inhibitor, wonderful. So SGLT2 inhibitor, the drug of choice, diabetes with any cardiovascular risk factor, be it NAFLD. We don't have the results yet. Many of are in the pipeline. But we are looking at others. We have the trial of heart failure, we have the trial of Cmes, we have the trial of renal failure. I think that's a wonderful drug, and MSLD is about to come, the results we are about to get. So yes, and I think all of our prescription, if it is, there's no problem, the problem of the infection that we usually see, because that is not there, we should give. In fact, one or twice infection, some UTI, some genital infection should not stop us from reinitiating SGLT2 inhibitor. So yes, it is the drug of choice.
Ma'am, one molecule which I would have liked you to speak maybe in a little higher volume is a poor man's PPR gamma agonist and insulin sensitizer, a molecule, wonderful molecule called metformin. Your take on the usage of metformin in NAFLD, MSLD, insulin resistance?
See, personally, if you talk of metformin is the after lifestyle modification, the first drug. So it is the drug for diabetes. We are giving it all the preparation, all the combination carries metformin. Like the SGLT2 inhibitor, there is not contraindication, there is a metformin in the prescription. See, if we simply say what is the role as such in the MASH, we don't have that data. Okay, we are getting a wonderful result as such in the MSLD or the MASH. So I will not say there is a wonderful result in that case, but yes, theoretically also we are working on the insulin resistance, we can give. But if you ask me per se for the MASH, is the metformin the drug of choice? Is the metformin superior than others? I won't go for it.
Ma'am, you mentioned a drug called tirzepatide. We are already using various GLP-1 receptor agonists, oral as well as injectable. I want to know from you, a drug, a molecule in the GLP-1 receptor agonist list which leads to more weight loss, is it more effective on MSLD?
Yes. So we have semaglutide injectable better than the oral semaglutide for everything, weight loss, MSLD, cardiac, ACV.
But not available in India as yet?
Yeah, not available in India as yet. And better than that, the results that we have is a tirzepatide, GLP-1, GIP agonist.
Still not available in India.
Few of my patients are on tirzepatide, and one of my patients.
They are buying it from somewhere.
They are getting it from
soon. Coming very soon.
It will come.
Yes, coming soon.
It will come. But yes, we can discuss.
But not showing tonight. Not showing tonight.
Yeah.
Okay. Ma'am, so we come to the molecule which we are talking about, the saroglitazone. Now it's been a molecule which we have seen has been in usage in India for at least 10-11 years. I want to know two things. I keep hearing from Supreet, my friend, that it has been approved by FDA. Has it been approved by FDA for usage in not in diabetic dyslipidemia but for MSLD?
It has not yet been approved by FDA.
It has not been yet approved. Also, I want to know from you, is it effective in transaminitis? Is it effective in insulin resistance? Is it effective in atherogenic dyslipidemia, especially of diabetes? Or is it also effective for reversing the fibrosis in MSLD?
So the data I have shown, this is mostly the data we have. The evidence for study is the largest study from India for the longer duration of time, and that is saying there is a regression in the fibrosis as well. So this is what the data is saying. There is improvement in the LFT, there is improvement in the diabetic dyslipidemia, and there is improvement in the fibrosis as well. And if we talk about, this is the data what we have that I've already shown. If you talk to me, what is my experience, what is my personal take, that we all can I think discuss on this molecule. So yes, I am giving this molecule. You know, the list of a person with diabetes goes on like this. We start with this, we give this, we give this. So a time comes, person is not able to lose weight. Maybe not a 40 GLP-1, already taking a GLP-1 inhibitor. CAPS for LSM is so bad. Struggling with the dyslipidemia. We add saroglitazone because see, we hardly have the molecules, and I have seen improvement. In the parameters. I don't know till what time we should give it, because some of my patients are now almost 9 months, 1 year, so on. If I don't find the benefit in 6 months or so, there are some patients, but yes, good number of patients are continuing and there has been improvement in the gap and the LSM with this molecule.
All right. My final question before I give it to the great people in the audience. If I get a patient today with a BMI of 34, he is a type 2 diabetic, he has got transaminitis, and he has got a liver stiffness which is borderline, and he tells me, I am going to do intermittent fasting. I do not have the money for any treatment apart from metformin and some of the cheaper molecules for diabetes that I am going to treat. And ma'am, you validated that the bottom line in NAFLD is weight loss, and he promises to lose about 10% of his existing body weight only by dietary manipulations and intermittent fasting. Is that acceptable?
Yes.
Absolutely.
If someone can do it, it is acceptable.
Without medication.
Yeah, absolutely. Why not? If someone, because people can do
So
it.
that is the message I also
Yes.
wanted to give.
Yeah, so that's why I said in my this thing that the foremost thing is the weight loss. If
Yes.
someone can do it.
Beautifully articulated. I would request Dr. Manish to please ask his question.
Ma'am, excellent, articulated and excellent, moderated. So I think you asked all
So
the
when
questions.
that is in the picture, I think the discussion becomes
Yes, absolutely, always.
everyone has
Hats
to
off
learn and look.
Yes, always. So ma'am, the question starts with the Willy Taylor cycle hypothesis, with the reversal of diabetes and liver being the center for diabetes. And many famous gastroenterologists and liver specialists said that the endocrinologists have had it wrong. The diabetes is the liver disease versus the pancreatic disease. But coming to that, the reversal of diabetes lies in reducing the fat content. Coming to the point of saroglitazar and the point tonight. Saroglitazar helping with lifestyle modifications, reducing the liver fat content. Will you take it as an addition to reduce and probably reverse? Point number one. Point number two, I heard a very famous lecture by a foreign author saying a dead tissue, which is fibrosis. Why are we talking of fibrosis getting alive? A dead tissue remains, fibrosis means scarring and a dead tissue. Yes, we know the hepatocytes have the potential to regenerate, but do they overtake the fibrotic part? So is that a part for consideration in this system?
So whatever the treatment we are talking about out here, any molecule, it has been approved till the pre-symbiotic stage. Once someone has entered into the symbiotic stage where fibrosis has a stage, F1, F2, F3, all the molecules they work till F3. Beyond F4 symbiotic stage, cirrhosis is not the reversible one. If someone has entered into cirrhosis, now they come the role of to deal with the complication of portal hypertension. So all the molecules are till the pre-symbiotic stage. They are not for the cirrhosis. It's not the reversible thing. And the first question, sir, that you asked was the which organ is, I think body, nothing is more important than the other organ. Every organ has a part. Now we don't talk about the two organs, it's a omnious, octave, and I think more organs to come in the line behind the pathogenesis of diabetes. And there is nothing called reversal. Nothing is reversible because someone is born with the gene. It is about to happen. If we are losing weight, if we are doing something, that part has to be continued. This called diabetes. Also, there is no reversal. It's just a remission.
So on this front, we just heard a recent in the RSDI, just recently concluded the national RSDI. So the German speaker was trying to propagate. So they did a small study where they did 14 days of water fasting and the liver fat came down to 0%. And they were trying to propagate that how can we make it a treatment for reversal and reducing that, coming back to tailored twin cycle hypothesis, that if you improve the liver fat content, you improve the pancreatic fat content, thereby improving the milieu.
But
That's a kind of
so whatever we are improving, that has to be done in a human body. So nothing for 14 days it can be done, but not for months or the years. That is the problem.
Dr. Sajid Parvez.
Thank you very much for a wonderful lecture and post-lecture discussion that was most enlightening, ma'am. Two things. Number one, when you talked about FIB4, there was an age factor. does it matter if 30-year-old and 60-year-old does the parameter change?
Yeah, so there are the risks for the onset and the risk for the progression. Both increases with increasing age. They say males more than 50 years of age and the postmenopausal ladies, they have got a higher chances and higher progression to cirrhosis if they develop MSLD.
How do we differentiate? I mean, you told us that it is less than 1.3 and more than 2.6. How do we differentiate? The age factor will multiply, I mean, that will increase or decrease the result. So, how to take into account
So age
that
is a
number?
risk factor. Age is a risk factor for everything, for all the cardiovascular metabolic risk factor. The fifth force score we are calculating is with the 4 parameters and that is a formula. So, yeah.
Ma'am, age is into that formula. Now, calculate it with the same ALT, AS, and platelet count and put 30 and put 60. The number will change.
So yes, number will change. So if someone is having the lesser age, I think the chances of progression are lesser.
Okay.
In any formula, we cannot take out one parameter and say that one line is written age less is less side effect, because the fifth one is not. It is the integration of these 4 parameters. But yes, there is a saying that if the age is higher, the chances of progression are more. But in fifth form, we are not seeing age alone. We are seeing the 4 parameters and then the formula is being right.
Now, number 2. Now, I am a GP, general practitioner, lots and lots of patients with fatty liver grade 1. No diabetes, nothing. Even you said that liver enzymes may be normal. When do I ask them to go for fibroscan? When do I do that? And number 3, any inflammation is basically leading to fibrosis. How do we stop that inflammation part? Fat is accumulated everywhere. But when it does convert into inflammatory change, and how can we stop it? That's all.
So the relation, the more the fat is accumulating, the chances of inflammation are higher. But there is no relationship between S1, S2, S3 in fibroscan versus F1, F2, F3. There can be someone with S2 with F3. That has been seen. So the first question, if someone has got a grade 1 fatty liver, if the person is, thin built, no cardiovascular risk factor, but I would say if the person has come to you, would have at least one cardiovascular risk factor and the grade 1 fatty liver, do get a fibroscan done if possible. Otherwise, ask the patient to reduce weight. Even if the patient is thin, then also ask them to do the resistance training to gain some muscle mass, to reduce the visceral fat, and keep the person under the follow. That is the one thing we can do. Maybe not going for any special imaging or the special investigation, but from our side, even if it is grade 1, the exercise and dietary restriction should be there.
Dr. S K Chauhan.
Recently, one of our friend was admitted with hepatic encephalopathy, and it was reversible. Ammonia level was very high. After 2-3 days treatment, it kept normal ammonia level. It was discharged. So, hepatic encephalopathy, can it occur without cirrhosis in early stage of fatty liver due to some other reasons?
It has been seen because maybe some other problem is complicating the picture. Maybe hypokalemia due to some reason, some drug intoxication. So there are n number of factors. Early cirrhotic can also rarely go into encephalopathy. We have to find out the reason. And someone has got into hepatic encephalopathy, we can stabilize the person. But we are not reversing the cirrhosis part. The person can again go into the complication. We have to just manage the complication part.
So I asked the gastroenterologist, fibroscan was not done. They said we are presuming that he is suffering from cirrhosis and fibroscan is not required because he presented with it.
Yes, sir, because see, if someone has got the signs of portal hypertension, someone has a nodular cirrhotic liver in the ultrasound, now we don't need fibroscan. Already the patient has got the complication.
Then you said metabolic syndrome is associated more with visceral obesity.
Yes,
So how do you diagnose visceral obesity? How will you diagnose? Not suppose patient is not obese, and then how will you diagnose
visceral obesity? So we have like the simple routine waist to hip ratio, waist circumference for Indians more than 90 centimeter, male more than 80 centimeter, female or the ratio 0.9 or 0.8. Then we have electrical impedance available with wellness gym these days, or we have DEXA machine that actually tells us about the fatty, but there are higher like CTMRs and all those things, but in clinical practice, even if we do the simple waist hip ratio, we can get the idea.
Last question, you said that advanced amyloiditis enzymes are not a diagnostic of hepatitis, steatoid hepatitis. So when the patient is advanced from fatty liver to steatoid hepatitis, how will you diagnose? Enzymes are not diagnostic then?
So it is through the ultrasound and it is through the fibroscan.
Any questions for you? Yes, PK Gupta sir.
Thank you, ma'am, for your giving such a good lecture on metabolic syndrome with liver. I want to ask a simple question. We as physicians get a lot of patients who come with us grade 2, grade 3, grade 1, fatty liver. There are no other things. But in such patients, what is the role of saroglitazole or UDCA? Which one is better and how you have to manage?
So if I have to choose between the two, definitely saroglitazole is better than UDCA. UDCA, I think, is we don't have the data. And clinical practicality is also waning. So I think go for saroglitazole over the UDCA. And the first thing is again the weight loss, weight loss, and choosing the drug molecules which helps in the weight loss, SGLT2 inhibitor or GLP-1s. Thank you.
Sir, I have two questions. You see, pioglitazone is PPR and it's also, but it causes fluidity. What about it? Saroglitazole. Does it have a, you see, very total action?
So does it?
About pioglitazone causes, you see, fluid retention, so it is contracting CCF extra. So what about this saroglitazone?
Yes, sir. So we don't have the concern of weight gain and fluid retention as such with the saroglitazone. Talking about the side effect profile, it is not a proof of pregnancy, lactation less than 18 years of age. In type 1 diabetes, it is not a proof for that age, but we don't have as such any side effect or risk parameters associated with it till now.
We are taking this platelets as a marker of the infib score as well as the NAFLD fibrosis score. What is the reason behind it? Is it caused thrombocytopenia due to the inflammation, or is there something other reason for the platelets to be taken in criteria? We are taking albumin, platelets, and etc. What is the reason?
You yourself have given the answer. So one is the inflammation and other is the liver destruction. The inflammation in the liver, that also causes thrombocytopenia.
Dr. Saxena, Dr. Jitendra Saxena.
In one of your slides, you were comparing the three molecules, saroglitazone, obeticholic acid, and UDCA. UDCA, you just said, is almost out, so it leaves you two molecules, saroglitazone and obeticholic acid. Are you dismissing obeticholic acid just because there are few trials, or is it that saroglitazone is financing this CME, so we are more?
No. See, we have talked about SGLT2 inhibitor and GLP-1 is out here. These people are not standing here. They are not financing us, right? We have talked about the PIOs as well. But if we talk about UDCA and vitamin E, actually the data, no one is working on that molecule. Let it be very clear. There is no latest data that we have for these molecules. And clinically also, like I haven't used them and I haven't seen other people in my place using them much these days. But with the saroglitazole, maybe the data is a bit new and we are using it. So that may be the reason for preference of saroglitazole over the UDCA.
But there is no harm in trying if the cost is the issue, because obeticholic acid is not cheaper.
Reduce fibrosis.
But see, the trial, the results are very less. If you see the slide, reduction by 10% as compared to 54%, so this is even not a meaningful result. The number of patients are also very less. So I could put it like that, the drug is cheaper, no pharma company is doing the trial, and if we don't have the result, we can't just perceived like that.
Dr. MBS Gandhi, sir.
Madam, recently I have come across a patient who is a lady about 60 years of age and she is a diabetic. For the past few years she is on insulin and recently she got her fibroscan done and it came out to be 87% liver involved with cirrhosis, very advanced stage of cirrhosis. And esophageal varices was also there and it was treated for that. Now the question is, if the patient is done to rule out, because it was not diagnosed earlier and now recently she got a shock of her life.
Yes, sir. Any diabetic person, it's very important for us to keep our eyes open. If NFTs are not good, ultrasound, usually invariably all the people by 1 or 1.5 years get it done. I would not say yearly ultrasound, but something has to be done to look for the liver. So whenever they are doing the blood parameter, we should always ask for the LFT. If LFT are deranged or if ultrasound is showing some fatty infiltration, then we should always ask for the fibroscan if we can.
Dr. Tulsi, sir.
Last but not the least. So, दो माइक दो
माइक के बिना चलेगा
Sir, 2 mics. I just need half a mic. Okay, so Dr. Bhawna, this was a great, incredible talk about fatty liver disease. NAFLD to MAFLD in 2020 and now MESLD since 2023, a paradigm shift in the way the definition today. Are you happy with MESLD? Are you happy with NAFLD? The definition MESLD versus MAFLD, where are you happy? I'm not happy with MESLD. I'm happy with the MESLD. Tell us.
I am happy with the M word.
With the
M word, metabolic syndrome.
Okay.
This is what I wanted.
Okay.
I'm not worried about FNS, I'm worried about metabolic. Now people will realize diabetes is not only the metabolic syndrome. Even a simple obese patient can have fatty liver, can have cirrhosis just because of obesity.
Absolutely.
So anyone with any metabolic syndrome need this.
So why I said was that the annals of hepatology, see, this journal talked about the study still to be published, coming in about maybe 2 to 3 months time, and 5,500 patients. See, they said this 3-year study published recently, it will be published very soon. MAFLD criteria better than MESLD because in predicting the risk of CKD, 30% were diagnosed to have CKD with high UACR and low eGFR. See, another Japanese study of 29,000 patients also said this is an accurate diagnosis. I'm talking about MESLD in identifying patients who would progress to liver fibrosis and CKD. So probably MESLD is a better definition because it identifies, at least apart from fatty liver, at least 2 of the 7 parameters, which probably would include KFT, LFT, Hep B and C, and of course dyslipidemia, low platelets and hypertension and high blood sugar, as compared to the MESLD, which would only identify one of the 5 severe risk factors. Yeah, ma'am.
Yes, the answer is given by you, sir.
Okay, great. She is happy as long as you use the M word, sir. She spelled it out beautifully. As long as you include metabolic in it, it's fine. It's fine.
For me, metabolic includes CKD also. You have to be
Absolutely, so very important. So management, the most recent AAC guidelines suggest that or reinforces the impact of lifestyle modifications and the standard of care today. See, losing at least 10% of body weight would probably, resolve to some extent your MESLD or MAFLD, whatever you call. And Dr. Chauhan dwelt upon insulin sensitizer, the pioglitazone, probably no longer recommended because of increasing, worsening heart failure, weight gain, diabetic maculopathy because of the fluid retention. So it's probably no longer recommended. But losing weight by any means,
See, is highly recommended. And talking about the diet, the low glycemic Mediterranean diet probably is the best dietary supplement which you could probably give to a patient, because you could reverse NAFLD, MAFLD or MASLD in 6 months' time by giving a low glycemic Mediterranean diet. Apart from this, Dr. Manish, where is he?
Manish has gone.
Okay, it's gone. So we talked about the GLP-1, GIP and the triple agonist glucagon. So probably they said that the recent study, the TRIUMPH study said that 90% of people, if you give this triple agonist, would reduce the hepatic steatosis. Thank you, ma'am.
Dr. Tulsi, sir, beautifully pointed out by you, and I may just add to whatever sir has said. Me and Manish attended courtesy Dr. Sen Gupta the RSSDI, which happened in November, and the message that we learned from Dr. Peter Schwartz's talk, who is the president of IDF, was that in India we take a lot of carbohydrates. That is not the problem. That's not the problem. The problem is that we take lot of fried carbohydrates, fat. Okay, we take fried carbohydrates. Forget about fats. So it is the fried carbohydrates which have unbreakable bonds, which the liver enzymes are not able to handle, and therefore what it does is that it is going to spoil the entire spectrum of the metabolic syndrome. The fried carbohydrates. Okay, please understand this. One is carbohydrate, another is fried carbohydrate. So make sure that your intake of fried, I'm sorry that we serve a lot of fried carbohydrates here. Dr. Kiran is continuously looking at me, and I'm very afraid of Dr. Podar, not Dr. Kiran Podar. The problem is that we must take care with the intake of the fried carbohydrates. Okay, that they have unbreakable bonds that contribute greatly to this immense epidemic that we are facing now of NAFLD, MASLD, whatever you call it. Dr. Kalra sir.
Sir, thank you sir, and wonderful talk, wonderful interaction by most of my friends, including my extra also Dr. Tulsi. Sir, the fried carbohydrates I want to add is more of the sweets, jalebi and all. They are all fried carbohydrates. And what I use in my practice to advise my friends who are having fatty liver to reduce 500 calories in the diet and also burn 500 calories by exercise. So that goes a long way, and I have succeeded most of the time. Whosoever followed, they were very successful to reduce their fatty liver. You mentioned about vitamin E high dose. And what is high dose? If we give 400, I don't think it is high dose.
600 milligram twice a day is being prescribed, left, right and center. And once it comes on prescription, it never stops, sir. It just continues like Sorbitrate and aspirin. These high doses are associated in certain studies with increased chances of prostatic carcinoma.
Lung cancers. Definitely, sir. What about versus this dose and 400? What about
400 milligram OD is an okay dose. Is an okay dose.
They will say placebo or pediatric dose, whatever. But we have been giving and finding good results till that. It's no side effect.
Just a word on coffee.
For
Good result.
good
Reduction.
We're not inviting for coffee.
Hold on.
Coffee ke liye bula
good
diya.
results. Sir, your question, sir. Let's wind it up. Let's wind it up.
So coffee has shown reduction in the MSLD scores actually. So there are a few papers in the European agencies are propagating it. I would not say go for coffee to reduce MSLD. We have better options.
Well, my last comment about whether diabetes is a liver disease or a pancreatic disease, glucose metabolism or fat metabolism, we are not sure. We are yet, it may be a mixture of all. So, thank you.
Wonderful. My last comment, and I would like Dr. Bhawna's response to it, that our children are very fond of taking zero cola drinks, you know. And it was a learning from RSSDI. I interacted with Dr. Peter Schwartz, and he said that you people are very fond of telling your children, your patients to take zero-calorie drinks, and there is a lot of sweetness in that. In Europe, it is going to be banned now. It is going to be banned. WHO has come out with the advisory that they are all carcinogenic and they should not be taken. Another problem that is said, and which is very pertinent to your practice, is that all these zero-calorie drinks, when they get into the intestines, what they are doing is they are changing your bacterial flora.
Yeah. What is the carcinogen here?
I don't know, sir. I don't know what is a carcinogen, but what they are doing is the immense harm to your bacterial flora in the intestines. And now, by now, all of you know, there have been multiple studies that this bacterial flora is extremely important, not only for your gut health,
For every system.
but for every single important organ in your body. And it is going to predispose you to MSALD, NAFLD, and watch out for these zero-calorie drinks in your children. So advise your patients, advise your children not to take these zero-calorie drinks, because they are going to change the bacterial flora of the intestines, which then is going to predispose them to multiple issues. And your last comment on this.
That begs the question, the role of probiotics and symbiotics in fatty liver.
Your comment.
Just one, what about, yes, sugar-free, sugar-free.
सब बेकार है भाई, शुगर भी नहीं लेती. One of the link in the diabetes pathogenesis, why the metabolic syndrome are on rise, and one of the changes is the microbiome change, and these packaged and processed food is the reason. And I don't think we should take probiotic to correct it. Anything artificial is artificial. And you talk about the carcinogen, aspartame has been banned. That is one of the things, and artificial sweeteners should not be given.
What about sucralose?
Stevia.
Should not be given.
Should not be given?
Should not be given.
It is recommended by USFDA.
Alright, we can discuss it over dinner. I would request all of you to give a big hand.